Welcome to EOR Review, where we bring you audible versions of end-of-rotation exam questions for people on the go. In this episode, we'll do 10 infectious disease questions that you can listen to when you're walking around, driving to your next rotation site, or studying for the PANCE. Let's get into it. Question 1. A 25-year-old female presents with fever, myalgia, headache, and a maculopapular rash that started on her wrists and ankles and spread centrally to her trunk. She reports removing a tick from her leg 10 days ago after hiking in Virginia. Physical examination reveals a temperature of 38.9 degrees and a non-blanching maculopapular rash involving the palms and soles. Laboratory studies show a WBC of 4,500, platelets of 110,000, AST of 75, and ALT of 82. Which of the following is the most appropriate initial treatment? A. Azithromycin. B. Clindamycin. C. Doxycycline. D. Amoxicillin. Or E. Trimethoprim sulfamethoxazole. I'll give you a second to review. The correct answer is C. Doxycycline. You're treating Rocky Mountain spotted fever. Doxycycline is the treatment of choice for RMSF regardless of age. Prompt empiric therapy should be initiated based on clinical suspicion without waiting for lab confirmation, as delayed treatment increases mortality. Azithromycin is not effective against rickettsial infections, nor is amoxicillin or clindamycin, and Bactrim may actually worsen infections. Question number 2. A 42-year-old male presents with a 2-day history of fever, watery diarrhea, and severe right upper quadrant pain. He returned 5 days ago from a 2-week business trip to India, where he consumed street food on multiple occasions. Exam reveals temperature of 38.7 degrees Celsius, right upper quadrant tenderness, and hepatomegaly. Laboratory studies were conducted which show a WBC of 13,000, total bilirubin of 1.5, AST of 68, ALT of 75, and ALK Phos of 210, which risk factor most strongly predisposes this patient to his current condition. A. Consumption of undercooked meat. B. Swimming in freshwater lakes. C. Drinking untreated water. D. Male gender. Or E. Underlying diabetes mellitus. I'll give you a second to review. The correct answer is drinking untreated water. The patient has an amoebic liver abscess caused by E. histolytica. Drinking untreated water in endemic areas is the most significant risk factor for E. histolytica infection. Contaminated water is the primary transmission mode for this parasite, leading to invasive amoebiasis, including liver abscess. Undercooked meat is not strongly associated with amoebiasis, and freshwater lakes are associated with schistosomiasis but not amoebiasis. Male gender is partially correct as there is a 10-to-1 ratio, but it's a less direct risk factor. Diabetes may worsen infections but is not specific to amoebiasis. Question number 3. 28-year-old male presents with a 3-day history of fever, productive cough, chest pain, and shortness of breath. He reports a really bad cold that improved then suddenly worsened. Exam reveals a temperature of 39.1 degrees Celsius, respiratory rate of 26 breaths per minute, decreased breath sounds with crackles in the right lower lobe. Chest x-ray shows lobar infiltrate in the right lower lobe. His WBC count is found to be 18,000 with neutrophilic predominance, and a sputum gram stain was completed showing a gram-positive diplococcus. Which of the following is the most appropriate empiric antibiotic regimen? A. Azithromycin. B. Ceftriaxone and azithromycin. C. Vancomycin and piperacillin tazobactam. D. Trimethoprim sulfamethoxazole. Or E. Ciprofloxacin. I will give you a second to review. The correct answer is B. Ceftriaxone and azithromycin. For hospitalized community-acquired pneumonia patients, IDSA ATS guidelines recommend a beta-lactam plus a macrolide, or monotherapy with a respiratory fluoroquinolone. Gram-positive diplococcus suggests staph pneumonia. Azithromycin alone is inadequate for hospitalized patients. Vanc and piperacillin tazobactam is excessive for CAP in healthy young patients. Bactrim is not the first line for CAP, and ciprofloxacin is inadequate against staph pneumoniae coverage. It is important to take into account that this patient has diabetes mellitus, which is a comorbidity that changes which antibiotics we use in the treatment of CAP. Question 4. 62-year-old female with type 2 diabetes and rheumatoid arthritis presents with painful vesicular lesions in a dermatomal distribution on the left side of her chest. She has been taking prednisone for 20 milligrams daily for the past 3 months for an RA flare. Physical exam reveals grouped vesicles on an erythematous base along the T4 dermatome. Which of the following is the most significant risk factor for postherpetic neuralgia? A, female gender. B, diabetes mellitus. C, age greater than 60 years. D, rheumatoid arthritis. Or E, corticosteroid use. I'll give you a second to review. The correct answer is C, age greater than 60. Herpes zoster and postherpetic neuralgia. Age 60 years is the strongest predictor for developing postherpetic neuralgia. Patients over 60 have a 50% or higher risk for developing this complication. Risk increases significantly with advancing age. Female gender is a slightly higher risk, but age is much stronger. Diabetes may increase the risk, but age remains the number one factor. Rheumatoid arthritis slightly increases the risk, but it's less significant. And corticosteroid use increases zoster risk, but not postherpetic neuralgia specifically. Question number 5. A 35-year-old male presents with fever, headache, myalgia, and abdominal pain for 4 days. He works as a sewer maintenance worker in an urban area with known rat infestation. The exam reveals a temperature of 38.8 degrees Celsius, scleral icterus, and right upper quadrant tenderness. Laboratory evaluation shows a WBC of 15,000, total bilirubin of 3.2, direct bili of 2.1, creatinine of 1.9, AST of 145, ALT of 160, and there is proteinuria and hematuria noted on UA. Which of the following is the most likely diagnosis? A, viral hepatitis. B, leptospirosis. C, Q fever. D, typhoid fever. Or E, dengue fever. I will give you a second to review. The correct answer is leptospirosis, or Weil's disease. Classic presentation is a sewer worker with rat exposure, biphasic illness progressing to Weil's disease, which includes jaundice and renal dysfunction. Leptospirus spirochetes are transmitted via water and soil contamination with infected animal urine. Viral hepatitis doesn't explain the renal dysfunction and the occupational link. Q fever is associated with farm animals such as sheep, goats, and cattle. Typhoid is a stepladder fever, relative bradycardia, and rose spots. Dengue fever is a mosquito-borne, without hepatorenal involvement, typically. Next question. A 45-year-old female presents with fever, headache, confusion, and neck stiffness of 24-hour duration. No significant past medical history is identified. Exam reveals a temperature of 39.5 degrees Celsius, nuchal rigidity, and a petechial rash on trunk and extremities. You perform a lumbar puncture, which shows an open pressure of 28 centimeters of water, which is elevated, a WBC of 1200 with 95% neutrophils, protein of 180 milligrams per deciliter, glucose of 30 milligrams per deciliter, and gram stain was performed, which shows gram-negative diplococci. Which risk factor is most strongly associated with this infection? A, HIV infection. B, sickle cell disease. C, living in college dormitories. D, recent neurosurgery. Or E, age over 65. I'll give you a second to review. The correct answer is C, living in college dormitories. Meningococcal meningitis should be what you suspect in this case. Living in college dormitories or crowded living conditions is a significant risk factor for meningococcal disease due to close person-to-person contact facilitating in meningitis transmission. HIV increases the risk for pneumococcal meningitis more specifically. Sickle cell disease has a higher risk for staph pneumoniae, but not meningococcal infections. Recent neurosurgery is a risk for skin flora or healthcare pathogens. And age over 65, meningococcal peaks in less than 5 in adolescent/young adults, but not necessarily in those over 65. Question number 7. A 32-year-old male presents with fever, chills, productive cough, and right-sided pleuritic chest pain for 2 days. He has a history of injection drug use and reports sharing needles 1 week ago. Exam reveals a temperature of 38.7 degrees Celsius, respiratory rate of 22 breaths a minute, decreased breath sounds over the right lung base. Chest X-ray shows a right lower lobe infiltrate with small pleural effusion. Blood cultures are taken, which are positive for gram-positive cocci in clusters. Which of the following is the most appropriate empiric antibiotic regimen? A. Ceftriaxone and azithromycin. B. Vancomycin. C. Piperacillin tazobactam. D. Trimethoprim sulfamethoxazole. Or E. Levofloxacin. I'll give you a second to review. The correct answer is B. Vancomycin. This patient likely has MRSA pneumonia, which is very common in patients who are IV drug users. Gram-positive cocci in clusters on a blood culture is most likely Staphylococcus aureus. MRSA is highly prevalent among injection users. Ceftriaxone and azithromycin is your standard CAP treatment, but it does not have MRSA coverage. PIP tazobactam does not reliably cover MRSA. Neither does Bactrim, as it's not a first-line treatment for severe staph pneumonia with bacteremia. And levofloxacin does not reliably cover MRSA either. Next question. A previously healthy 18-year-old male presents with fever, sore throat, fatigue, and tender cervical lymphadenopathy for 5 days. He denies cough or rhinorrhea. Exam reveals a temperature of 38.5 degrees Celsius, exudative pharyngitis, bilateral cervical lymphadenopathy, and splenomegaly. Laboratory evaluation shows a white blood cell count of 12,000 with 60% lymphocytes, many of those atypical. Heterophile antibody test is performed, which is found to be positive, and a rapid strep test is conducted but found to be negative. Which manifestation is most likely if this patient is started on amoxicillin? A. Anaphylactic reaction. B. Stevens-Johnson syndrome. C. Maculopapular rash. D. Fixed drug eruption. Or E. Serum sickness. I'll give you a second to review. The correct answer is maculopapular rash. The patient has EBV infectious mononucleosis. A maculopapular rash occurs in 90% of EBV mono patients who are given ampicillin or amoxicillin. This is not a true allergic reaction, but an interaction between the drug and the virus-induced immune response. Anaphylaxis is an IgE-mediated reaction unrelated to EBV infection. SJS is a severe cutaneous reaction and not specific to EBV amoxicillin reactions. Fixed drug eruption are recurrent patches at the same sites, not EBV related. And serum sickness often has fever, arthralgia, and urticaria about 1 to 2 weeks later. Next question. A 50-year-old immunocompetent patient presents with gradually worsening headache, confusion, and low-grade fever for 3 weeks. No recent travel, but the patient has been cleaning his backyard chicken coop regularly. Exam shows a temperature of 38.1 degrees Celsius, mild neck stiffness, and so you perform a brain MRI, which shows multiple ring-enhancing lesions. Next, you obtain a lumbar puncture, which has an opening pressure of 25 centimeters of water, white blood cell count of 75, protein of 95, glucose of 40, and an India ink test is done, which is positive for encapsulated yeast. A cryptococcal antigen test is performed, which is also positive. Which is the most significant risk factor for this infection in this patient? A. Advanced HIV infection. B. Exposure to chicken excreta. C. Recent travel to endemic areas. D. Chronic corticosteroid use. Or E. Prior neurosurgery. I'll give you a second to review. The correct answer is B. Exposure to chicken excreta. The patient has cryptococcal meningitis. Exposure to bird droppings, especially pigeons and chickens, is a key risk factor for C. neoformans. The organism is found in soil contaminated with bird excreta. While HIV is the top risk factor globally, this patient is immunocompetent. Most common risk globally is HIV, as recently stated, and recent travel shows C. Gatti has geographic clustering but no travel history is associated with this patient. Corticosteroid use, patient is immunocompetent with no steroid use. in prior neurosurgery is wrong because not a specific risk factor for cryptococcal infection. Question number 10. 55-year-old male with poorly controlled type 2 diabetes with a hemoglobin A1C of 9.8% presents with severe throbbing right ear pain, purulent drainage from the ear canal, and fever for 3 days. Exam reveals a temperature of 38.9 degrees Celsius, erythema and edema of the right external auditory canal with purulent discharge, and tenderness with tragus manipulation. Tympanic membrane is not visualized due to canal edema. Which of the following is the most appropriate treatment? Oral amoxicillin, topical acetic acid drops, oral ciprofloxacin and topical ciprofloxacin drops, oral trimethoprim sulfamethoxazole, or E, topical neomycin polymyxin B hydrocortisone drops. I'll give you a second to review. The correct answer is C, oral ciprofloxacin and topical ciprofloxacin drops. The patient has malignant necrotizing otitis externa. Malignant otitis externa requires systemic and topical anti-pseudomonal antibiotics. Ciprofloxacin is the drug of choice due to excellent Pseudomonas activity and bone penetration. Poorly controlled diabetes is a major risk factor. Amoxicillin lacks Pseudomonas aeruginosa coverage. Acetic acid drops are only for uncomplicated otitis externa. Bactrim has limited Pseudomonas activity. And topical only is inadequate as systemic therapy is required for malignant otitis externa. Thank you for listening to this episode of EOR Review. I want to welcome you back for future episodes. Stay tuned. Thanks.